It's good to be here tonight. We're going to be talking about thyroid, and this is a very underappreciated portion of healthcare. I would say that most people who have hypothyroid are going to be told when they get tested through the traditional measures and they go to the medical doctor or traditional doctors that look at this in the traditional sense, they're going to be told, most of these cases are going to be told they don't have a thyroid problem. And the reason why is because there are six major patterns of hypothyroid, and only one of them is what's called a primary hypothyroid. Primary means there's something going on with the thyroid itself. 5 of the patterns are not from the thyroid, but secondary or tertiary things or other things that's actually driving a low functioning thyroid. So I'm going to just ask right now as we're going here. I have Dr. Annette is, I see you're on, I think you're on. If you are on, so give me a shout out. Let me know that you can hear me. So, or if somebody's watching and you can send me a question and tell me, hey, I can't hear you. Or somebody actually say, hey, I can hear you and I can see you. Okay, so let's get started here. So profile patterns that revolutionize patient care, 6 patterns of hypothyroid. Well, I thought this was kind of funny right here, right? So the doctor's sitting here and the doctor says oh, wait a second. I'm sorry. The labs came back all good. There's nothing wrong with your thyroid. But, at that time, she's got a big, huge goiter sitting out there. It is actually true. That can happen in many cases. So, good sounds good. Okay, good. I heard some things. So we are definitely on the go here. I'm trying to get rid of my thing here. Okay, good. So hypothyroid can be a canary in the coal mine, meaning this. I don't know if you remember back in the day, but before they had more sophisticated measures, if you were in a coal mine or any kind of mine, you could have deadly gases that are released. Problem is you can't smell them, so there's no real way for us to detect them, and they couldn't detect them. So what they do is they put canaries in the coal mine with them, and if the canaries died, that meant get out quickly because they are there. So we have this saying that says the canary in the coal mine. When somebody has all the signs and symptoms, and I'm going to review them because I want you to be good at this. If they have all the signs and symptoms of hypothyroid, then it is a canary in the coal mine. It means something's going on in the system, and it's an invitation for us to investigate and figure out exactly what that is. I want to remind folks that, there's a process. There's a clinical process we follow. Patient enters into the clinic and we do questionnaires. Questionnaires are going to help us kind of nail down kind of the major drivers of what's going on. It's also going to tell us family history and show us some other facts. And then we're going to observe the patient, and then we're going to do a physical exam. After we do the physical exam, then we're going to order labs. Once we order labs, we're going to develop a strategy to mitigate, or we're going to develop a strategy that'll help us get patients more stable in whatever area is showing up. And then the ultimate, once we do that, then we really want that patient to be lifetime. Now, it doesn't mean you're going to check them once a week, once a month, whatever. I have some patients that are still my lifetime patients. I don't check them, but once every 6 months or maybe once a year, we'll do a big full lab workup on them, do physical exam, history, check out what's going on, make sure things are going right. Most of these are mainly like wellness patients after they've already gone through the process of us working through their issues and getting them to a better place. So you want to order the clinical process when you're dealing with thyroid, when you're dealing with any patient. You want to order the clinical process, and what does this mean? Well, we do the history, we do physical exam, observations, physical exams, lab workup. Now I'm going to show you this. I put this in here. You're going to love this slide, or I hope you do. These are the patterns that fit with thyroid. Now, if you've not seen any of our teaching before, let me encourage you on this, that when we see patients and we do blood work, we do not want to just simply go straight to the blood work and skip the physical exam, skip the history, and forget all about that. That's not good, efficient work. If you want to get really good at this and be really efficient, you want to pay attention to what we call patterns. What are patterns? Patterns are certain things that emerge that give us the information that says, hey, let's look at this condition. So If somebody comes in, the 5 most common complaints that we see when somebody has an underfunctioning thyroid is fatigue, weight gain, brain fog, constipation, dry skin. Now, because some people with hypothyroid, they can have irritable bowel, we can have other inflammatory issues going on in the gut, in the GI tract. So therefore, even though hypothyroid will slow down the bowel movements, they could have other inflammatory things going on, and it is actually increasing the bowel movements, so they don't really notice the constipation. So I have a caveat on that. So anyway, if somebody comes in and they say, "Hey, I have weight gain, and I'm on a, I work out and eat like a bird, like I'm doing 90 minutes of, aerobics, and I'm doing weightlifting, and I'm eating, 1,200 or 1,500 calories or whatever the case may be, and I'm just eating like a bird, and I'm still gaining weight." This is a hallmark of a low thyroid case. So if they have fatigue, weight gain, brain fog. Now, as it turns out, T3, which is the hormone that is the most active, that really drives that DNA and makes you do the things that DNA does, which is make proteins, the T3 also is, and let me just put this out. Okay, so T3 also is part of the process of you making acetylcholine. Now, acetylcholine is a neurotransmitter, so it's a chemical that's in the brain. So it's a neurotransmitter, and that neurotransmitter's job is to provide speed, processing speed to the brain. So dopamine gives power to the brain. Serotonin gives synchrony to the brain. Well, as it turns out, GABA relaxes the brain. Glutamate turns on the brain. That's the reason why monosodium glutamate, if it reacts badly with you, really doesn't do well. But acetylcholine's job is to provide speed for the brain. And guess which part of the brain is rich with receptors that like acetylcholine, that turn it on? And that would be the hippocampus. And the hippocampus is the place where you convert short-term memory to long-term memory. That's the reason why you go in the kitchen, you can't remember why you went in there, because the hippocampus is not converting memory at a rapid enough speed. If you have low acetylcholine, which is essential to have thyroid to do that, if you have low acetylcholine, you're going to have slow processing speed, you're going to have brain fog. It's very common. And dry skin. All right, so observations. You can, when you're just looking at somebody, this is not necessarily the physical exam. You just look at somebody at Walmart, if you will. They have that coarse hair or thin hair, periorbital edema, that's that edema that goes under the eyes, and lateral third of their eyebrows are diminished or gone. How I like to measure that, and I'm looking for a pin right here. So, but I don't see anything, that's fine. You take the lateral margin of the eye, right, and go straight up, and the third, that's the lateral third. So if it's diminished or gone, that means low metabolism. Because guess what? If you have low metabolism, guess what the brain will do? The brain will say, you know what, some things are less essential. And one of the things that gets lopped off is that third of the eyebrow, because for whatever reason, the brain says, well, it's not that essential that you have that lateral third of the eyebrow, so it doesn't expend the energy to do that. It's just like your fingernails start breaking up and getting brittle when you have low thyroid. A lot of things can do that but you have low metabolism. So if you have a patient, let's go back to patterns. If you have a patient that has fatigue, weight gain, and they're exercising, moving their body, and not eating a lot, brain fog, constipation, dry skin, then you want to start looking at these observations. So I will stop right here with the patient. So if they have on their list of things, of symptoms, if they have 3 or 4 out of 5 of these first symptoms, and I look at them, they have periorbital edema and lateral third of the eyebrows gone, I can assure you they've got a low functioning thyroid. But most of these cases are not going to show up in the traditional care, because TSH is what they use, and sometimes total T4, and that's not going to catch it in most of these cases. So, and you guys, if you've done this work, you know exactly what I'm talking about. Patient comes in and they say, well, I've been checked by 5 doctors and everybody says I do not have a thyroid problem, but they've gone to Dr. Google, not a bad thing. They've gone to Dr. Google, and Dr. Google has shown them that they have all the signs of hypothyroid, right? And so they probably do. Okay, so now the physical exam. So So now we're moving through the process. We've looked at the questionnaire, we've looked at them, and now we're going to do an actual physical exam. Now you're going to observe lateral third of the eyebrow diminished, dry skin. Best way to look, best place to look for dry skin is in the heels. In the heels will show dry skin perhaps faster or more earlier in the process than any other place. So you want to look at those heels, right? Coarse hair, thinning hair, diminished Achilles reflex. As it turns out, hypothyroid, of course, will decrease your reflexes, but for whatever reason, and I don't know the reason, but for whatever reason, it will go after the Achilles reflex more. It possibly has to do that it's further away from the center of the body. I don't know for sure, but that could be. But anyway, diminished Achilles reflex. You want to check that. Scalping tongue, and I'm going to show you one of these here. Myxedema, you don't see that a lot, but in the tibia, myxedema, periorbital edema, brittle fingernails, abdominal bowel sounds, and hepatobiliary system. You're just not hearing many bowel sounds because it's not moving that much. Pitting edema, cold hands, cold feet. So then you have the 6 patterns of hypothyroid. Now, let me say this part. This is really important, okay? So if you have a patient that is displaying a lot of these issues from the history, observation, and physical exam, you have a low functioning thyroid. But what you don't know is why. You don't know which of these 6 patterns, because guess what? No matter what the pattern is, these things will all look similar. Whether somebody has Hashimoto's, whether somebody's an underconverter of T4 to T3, it doesn't make any difference. It's going to show up the same as the history, observation, physical exam patterns. In other words, you can't determine looking at these patterns really which one it is. You have to do that through the blood work, and that's what we're going to go through. All right, so here are the 6 major patterns. I have this as a slide just so you have it somewhere. But primary, if you have a primary hypothyroid, then you're going to have an elevated TSH. A perfect TSH is going to be 1.8 to 3.0. Now, we don't really think that much about a primary until that number really gets over 4.5. Then we're getting more. In fact, from a diagnosing standpoint, somebody could be at 3.5 or 4.0, and they have what's called a functional primary hypothyroid, but it's not something you could diagnose and put on a ICD-9 and say that's hypothyroid. You can only do that when it goes over, because that's the clinical range. The 3.0 is the functional range. Okay, so if somebody has that, major drivers, the most common thing is when somebody has an elevated TSH, especially if that TSH gets to 6 or 7 or higher, most of these cases, and I'm talking 80-90% of these cases, are actually Hashimoto's. And it is important to know whether it is or not, right? Because there's a difference between having an autoimmune hypothyroid and just simply a hypothyroid because you have low selenium or low iodine or low zinc or inflammation. Different things. I'm going to give you some clues on that in just a moment. I want to show you something really quick, okay? History. You're going to have all these, and you can take these slides, and this is what I call a money slide. Like, you get this slide, it has a lot. These are all of your patterns, right? These are all the things that fit the pattern of hypothyroid. And as I said, if you have a majority of these, you have hypothyroid. Like if you have fatigue, weight gain, brain fog, constipation, dry skin, if you have 3 out of 5 of those, 4 out of 5 of those, you probably have hypothyroid. But then it seals the deal when you see that lateral third of the eyebrow diminished or gone, coarse hair, thin hair, periorbital edema. That's just observation. That's how you can just look at somebody in the face and see that. Well, when you get to the physical exam and you see things like a sluggish Achilles heel reflex, scallop tongue, these things, then we know you have a hypothyroid. What we don't know at that point is which pattern it belongs to. So when we look at patterns, we have elevated TSH, and we talked about that. Now, going to the secondary, the most common driver, see, I have this listed up here as driver. The most common driver of secondary hypothyroid or secondary hypothyroid is hypoglycemia. That's the most common cause I see, and junk food diet stress can also do it. Tertiary could be infection, chronic, or acute. I want you to stay with me because I'm going to go through all these. I'm just giving you the slide now so you kind of know where we're going. Under conversion, high cortisol, liver congestion, all those. Over conversion, that's where T4 is over converted to T3. That happens with ladies with PCOS, elevated testosterone in the ladies, elevated estrogen in the ladies. So this is the one that can be caused by birth control pills and as well as the estrogen therapy, which is actually quite interesting. If you take birth control pills, you automatically, immediately have become hypothyroid, functional hypothyroid. And then thyroid resistance happens with medication, environmental pollutants. I want to get into this program a little bit more so that we can get to the juicy parts with the blood. But as I said, we have to talk about these patterns because these patterns are ultra important to understand. So if a person comes in and they don't have any of the signs, weight gain, fatigue, and they don't have anything, they don't have hypothyroid, right? They're not going to really have that, and you're probably not going to see that in the blood work. Okay, so this is something I like to do. It's called the metabolic assessment form. And when we use the metabolic assessment form, we can start looking at different things like blood sugar, how's the microbiome, how's the liver, and so on and so forth. Well, as it turns out, there are things, as we can see from the earlier slide, there are actual things like blood sugar issues. I just talked about hypoglycemia. There are things that actually you can see emerge in patterns for hypothyroid that are not thyroid specific. And I'll give you an example. If somebody, this is on the metabolic assessment form, but if somebody has bowel issues, and this one specifically talks to the colon. If you haven't seen the metabolic assessment form, let me explain it this way. In the metabolic assessment form, it has categories. Category 1 has to do with the colon, and the most common reason for people to have issues in this. So if somebody has a 1 here, 2, or 3. 3 means you experience it all the time. 2 means 50% of the time. 1 means 25% of the time, and 0 means none. You don't have it at all. But if somebody's, marking 3s and 2s and 1s through here, without even looking at any specific one, I can tell you one good piece of information is they probably have a problem with poor microbiome diversity, meaning the good bacteria in their gut is not healthy. Another thing, they could have IBS and they could have other things as well, but you really want to look at microbiome diversity. And guess what? 20% of your thyroid hormone is converted, T4 to T3, in the GI tract. So if the GI tract is not working right, guess what? You're not going to convert as well, and you can be an underconverter. So if you see this, like you see somebody comes in, they have weight gain, a brain fog, they're fatigued, dry skin, constipation, they have all of those, and you look at them and they have the lateral third of the eyebrows gone, well, you're going to know already that this is probably hypothyroid. And then you're going to go to this section and say, oh, well, guess what? They have poor microbiome, or they've got something going on in the GI tract. We're going to have to address this as part of the package of understanding on how to get the thyroid function improved. Okay, so this is the Bristol stool chart right here. We really want to kind of be in this area right here. If you're that way, you're more watery stool. If you're that way, you're more constipated. All right. So here's another one. Guess what? If I can draw this out right here. So we have the liver sitting right here. We have the gallbladder, and then we have this that comes down here, and here's the small intestine. Here's the stomach. All right. So we have hydrochloric acid in the stomach, right? And just to complete this, we have the pancreas sitting here, and it feeds in right there. Okay, so hydrochloric acid is what starts the digestive process. It helps you absorb calcium, zinc, B12, but it also helps break down proteins. And if you don't break down proteins well, it sets you up for food sensitivities and all that. But as it turns out, if you have TSH, that's out of balance, high or low, it can affect the production of HCl. So in this pattern right here, this category number 2 actually speaks about low HCl or low or hypochlorhydria. So if somebody has excessive belching, burping, or bloating, especially right after they eat, they do a 1, 2, or 3 on here, that's a good indicator clinically that they have low hydrochloric acid. If they have gas immediately following a meal, and some can be offensive breath because your hydrochloric acid is killing bacteria, and bacteria stink. So if they have any of these, then they probably have low hydrochloric acid. Now, it is indirect, but it could be related to the thyroid function. Here's another one that it takes we take cholesterol. Let me get my white pen out here. We take cholesterol and we take bilirubin, and what it does is it mixes together to make bile. Bile goes down here, and the gallbladder sucks it up just like a straw, and it sits right here. Well, your hydrochloric acid mixes with food, and it gets in the small intestine. That causes a significant drop in pH in the top part of the small intestine. This is what activates, this is one of the things, not the only thing, but it's the primary thing that activates your pancreas to release digestive enzymes. It's also the primary thing that releases, where you secrete cholecystokinin, that causes the gallbladder contract to release the bile. So bottom line is, if you have low hydrochloric acid, you're not going to have good bile flow. But guess what? There's also another piece of this, and that's this. It takes a lot of thyroid oomph, if you will, to really make this process happen. It's one of the most highly metabolic activities we do physiologically. So if you have underfunctioning thyroid, you're going to have an underfunctioning bile flow. Okay. If you have an underfunctioning bile flow, then if you eat greasy or fried foods, fat foods, you can have a problem with them because that's how you digest them. Now, here's the interesting thing. When you ask a person about this, you ask them, do you have problems with greasy or fried foods? Oh, no, I don't. Then you ask them, well, what would happen if you ate a greasy or fried foods? Well, I don't know. I never eat it. Then you're like, well, why don't you eat it? Because it gives me problems. Well, you're like, I asked you that before, but sometimes people don't do that. So you really want to drill down. And if somebody's had a history of gallbladder attacks, there's 3 main reasons for people having gallbladder attacks. I'm talking about in the long term. One is an underfunctioning thyroid. Another one is insulin resistance, and another one is high estrogen. So this is very interesting. When ladies, females, young females, are taking birth control pills, they will cause themselves to have a functional hypothyroid, but that on top of high estrogen is going to really slow that bile down, and it's no secret why a lot of ladies taking birth control pills get their gallbladder taken out, because it gets sluggish bile, turns to stones, and they go to the hospital and do that. By the way, I haven't seen a gallbladder yet that we weren't able to turn around. Now, there might have been one I've seen in the past that I just wasn't aware that happened, but I don't remember one. I think a month ago, I had a lady call me from the hospital, and she said, I'm scheduled for surgery tomorrow morning. What do you think? And I talked to her, and I said, I think you're safe for the moment. So if you can, let's get out of the hospital and let's get down here. She's from St. Louis. I'm a couple hours away. Get down here and let's start working through the process. And that was about a month ago, and she's feeling much better. She still has her gallbladder. So I'm not, this is something that you want to look at for your pattern for hypothyroid. Okay. Another thing, hypoglycemia. If they irritable meals are missed, they feel better, they get eating reflex fatigue, or they get lightheaded meals are missed. This is a sure sign of that in the hypoglycemia. Now, this is the one on the metabolic assessment that specifically speaks to thyroid. So if they're sitting down here, they've got this, like this, and they've got this. Well, you can see without even looking, then you want to look through those to see which one they're having problems with. But if you see that many like 1s, 2s, and 3s in there, they have a hypothyroid at some level. You just have to figure out why. And by the way, if you see that they have those patterns that we talked about earlier, weight gain, fatigue, if they have brain fog, if they have, I just look at that, dry skin and constipation. There went my brain fog. It's coming back though. Okay. Or if you see an observation, periorbital edema, lateral third of the eye's gone, you do the physical exam, they have dry skin, they have all the signs. We know that they have a hypothyroid. We don't know what it is. But when we look through the metabolic assessment, we can start getting an idea of what could be driving it, right? So let's move on. All right, so observations. I'm just going to go through these pictures very quickly. This right here is periorbital edema, and you can see the lateral third of the eyebrow is gone. So that's a good sign, and you can see coarse hair. That's hypothyroid. So you can see this is pre and post. This is not a patient of mine. This is just a pre-post, and you can see the difference in the hair. You can see a difference in the skin and also the weight. All right. So you see the Periorbital edema. We don't know about the eyebrows. She might just colored them in. All right, so we like to draw a line straight down from here, and this is where we get, from here out, if they're missing that, then that is going to be considered a lateral eyebrow gone. Right now, you could see this from a fast-moving bus, right, or riding a horse and looking through a window. That is a hypothyroid. I can assure you that's hypothyroid. We don't know which pattern, but it is hypothyroid. Swelling there. Sometimes it's difficult swallowing. But here's a good one. I want you to look for this one. When you see, this is called scalping of the tongue. If you have inflammation in the GI tract, or if you have underfunctioning thyroid, then your tongue will swell up and push up against the bottom of your teeth, and you'll see this scalloping, right? So here's dry skin. That is the tibial myxedema, and this is you'll have poor blood flow in the hands and feet, your capillary refill. Because you have poor blood flow in the feet, you can also have funguses show up. All right. This is the hair. This is the dry skin on the heels. You're going to see it more there. Okay. Dry skin on the heels. And by the way, just so you know, if you see a dry heel like this on one side and it looks clean on the other, this is the left side of the body. So that means the right side of the brain is weak, because things will show up more. If you have a weakness in your right brain, things will show up more generally like this on the left side of the body, and vice versa. All right, so patterns of hypothyroid. Here's the physical exam. Now, this is a classic example. When I see a scalloping of tongue that is this demonstrable, then this is more related to hypothyroid and not GI inflammation. They might have GI inflammation, but I equate it more to low function thyroid. Now, if you have a little bit of scalloping, it could be either, right? So it's a little bit of scalloping there. But you see scalloping that looks like that, wow. Now, my clinical experience is a lot of times you're really looking at the hypothyroid. Look at the periorbital edema, the puffy face, lateral eyebrows, dry coarse hair. So you're going to palpate that thyroid. You're going to do your diminished reflex to see if it's diminished in the Achilles. Abdominal exam, you're going to list some bowel sounds. You're going to have slower bowel sounds in general. Now, as I said in the beginning, if you have irritable bowel syndrome or some kind of inflammatory process in your bowels, then what's going to happen is it can negate that, and you might hear a lot of bowel sounds. The other thing is you want to get down here and palpate that liver really good, because as it turns out, if you don't have good bowel flow and that gallbladder gets inflamed, you'll push in there and that'll be sore. So keep in mind, you're doing all these things because you're looking for patterns. And I've reiterated this a whole bunch, but you look at the history: weight gain, brain fog, fatigue. You're going to have constipation, dry skin. You look at the observation, lateral of the eyes, and you're going to see maybe thinning of the hair and so on and so forth. If you do that, when you do the physical exam, diminished Achilles reflex, look at the lateral third of the eye, look for scalloping, dry skin. These are all things you want to look at. When you see that, you have a developing pattern of hypothyroid, and then you do the abdominal exam. Just because the gallbladder in that area is tender doesn't mean you have low thyroid. But when you see all this pattern go together, it fits into that pattern, right? So let's start looking at the blood chemistries now, okay? So first off, let's do a little bit of thyroid diagramming here, okay? So here's the brain, the nose, and the mouth, okay? So here is the hypothalamus, and here is the pituitary, okay? So the hypothalamus sends thyroid-releasing hormone to the pituitary, and that activates, and the pituitary is activated other ways, but the strongest activator of the pituitary to release TSH is from that TRH. So it goes down to the thyroid, and the thyroid primarily, not exclusively, but primarily kicks out T4. Now, T4 is a molecule that is a 2-ring structure that has 4 iodines coming off of it. 4 iodines coming off of it, okay? So you have an enzyme, and by the way, let me back up. T4 is only 1/10 of the strength of T3, and you don't really use it that much as far as activating the DNA. But what you do is it has a half-life of like 2 weeks, so it can float around the body and it becomes an excellent resource when you need thyroid in any part of the body. So it's floating around just looking for a place to be. So that's what it's mainly a transporter, right? So you have an enzyme, and it's called 5' deiodinase, and that deiodinase enzyme will actually take off this iodine, and then it becomes T3. Well, T3 has a half-life of anywhere between an hour to 24 hours, so it is actually pretty volatile. So this is what it does. Let me go back to my white, but this is what it does. Okay, I'm having a struggle on my pen. So hold on a second. See if I can get this back going. All right, T3, and here is the cell, and here's the DNA of the cell. Cortisol and thyroid are the only hormones that actually have receptors directly on the DNA. It's pretty powerful. Estrogen, testosterone, progesterone, insulin, all those do not do that. They go to the cell membrane. All right, so thyroid lands straight on the DNA. DNA's basic function is to make proteins. So those proteins are specific for that cell. So a liver cell is only going to make the proteins that go with liver function. So when T3 lands on that DNA, it helps it produce the proteins necessary. One of the proteins it makes, or some of the proteins it makes, is it helps you build the mitochondria. And of course, as we know, food goes into the mitochondria and comes out as ATPs, or energy. So if you have low mitochondria in your cells because you have low production of protein because of low functioning thyroid, then what happens is you don't convert food to energy very well. You just convert food to fat. That's the reason why you can eat very little food and you can still gain weight because of that. Okay, so now T3 and T4 actually will feed back to the pituitary and the hypothalamus. And so the most important thing to understand about thyroid function is this: the thyroid can't think for itself. It's only responding to what the brain tells it to do. So thyroid function starts, and this is a very important part, starts in the brain. So the brain has to tell the thyroid to kick out thyroid, and then T4, T3 feed back to the brain, hypothalamus, pituitary specifically, so that the brain knows how much thyroid is in the system, and then it accordingly sends out the TSH. All right, so this is pretty much the thyroid cycle that's happening. So let's look at that. All right, so let me, in a very short manner, draw our picture here. Here's the thyroid, and here's T4, and here's T3, right? And here's our hypothalamus and pituitary. I'm just going to draw this out real quick to give you a quick rundown of this, okay? And here's the TSH. All right, so the TSH goes down. We should see that between 1.8 to 3.0. If it goes low, there's a reason for it. If it goes high, there's a reason for it. Now, let me just say this. You cannot just look at the TSH and come to a conclusion. Remember, you don't look at any blood unless you include patterns. There's patterns in the history, observation, there's patterns in the physical exam, and then there's patterns in the blood work. All of these things have to fit together, and then you can make a more stable assessment of what's going on with the patient. So T4 is made, and then T4 total should be 6.5 to 12. Free T4 should be 1 to 1.1. T3, total T3, you have those. Actually, I don't have that right here. So this is 2.6, and I believe that's 3.2. 2.6 to 3.2. Okay, so those are our numbers. We'll refer back in just a moment. All right. There's one other thing I need to go through before we actually go through the specific blood work. And then I'm very sorry. I think we lost 10 minutes of the very first when we didn't see the slides. By the way, I wasn't recording that either, so that won't be in the recording. So if you were here, you actually had the advantage of actually hearing what that was, if that gave you some benefit. All right, so let's talk about this, because as I said, we have patterns with history, observation, and physical exam. Now, we also have patterns with thyroid that are non-thyroid analytes. And I'll give you an example. I'm going to go through some of these. All right, so one thing, here's the liver right here, and as we said, here's the gallbladder, and here's this little tract going down here in small intestine. Well, most of your cholesterol is eliminated through this process of bile. So that's how you get rid of, and you make more, you eat more, and then you get rid of it, and so on and so forth. If you have sluggish bile, then what will happen is you won't process the cholesterol as well, making the bile, and then the cholesterol will simply back up in the blood, and then you'll have high cholesterol. Now, as just a really quick rule of thumb, okay? When we look at cholesterol, we always look at the cholesterol to HDL ratio. When that ratio's over 5, we really do consider the fact, it's not the end-all be-all, it's just a very actually small piece of the puzzle with cardiovascular disease, but it is a piece of the puzzle. So when that's over 5, we think cardiovascular. So somebody has give you an example, somebody has a cholesterol of 250 or 280 or 240, whatever, and their cholesterol to HDL ratio is at an 8.5, then I'm going to say there's a good chance that that cholesterol being high could be related to cardiovascular disease, fatty liver, something done that way, okay? On the other hand, if somebody has a cholesterol of 250 and their cholesterol to HDL ratio is like 3.5 or 4, I'm going to tell you, if you have all these other patterns going, it's not cardiovascular, that is hypothyroid. And I would say the most common reason for elevated cholesterol that's not cardiovascular disease related is going to be hypothyroid. So you want to pay attention to that. You see elevated cholesterol, and you have some of these other patterns, you can start thinking, yeah, maybe it's hypothyroid. Now, we have a tight range for alkaline phosphatase, much tighter than the clinical range. If you have a alkaline phosphatase that's lower than 60, the most common reason for that is low metabolism. And of course, hypothyroid is going to be low metabolism. But there's another thing with this, and that's this. Here's your liver, here's your gallbladder, right? Here's coming out of here. And this is the small intestine here. So if you have sluggish bile here, which can be related to hypothyroid, if you have sluggish bile and you get some bile sludge in there, and bile's just not flowing well, or you have some stones in there, guess what? That can make the alkaline phosphatase go over 80. So if you see alkaline phosphatase over 80 or under 60, either one of those can fit part of a pattern for hypothyroid. Depressed white blood cells. Well, it makes sense, right? You have low metabolism. You're simply not going to have a strong immune system. And that's the reason why these people are always getting colds and they're not feeling well and so on and so forth, right? Elevated MCV. So there are 5 major categories that can drive anemia. One, of course, is the most common, is iron deficiency anemia. 2 is inflammation. 3 is low B12, and 4 is low folate, and 5 is low thyroid. So those are going to be your patterns for anemia. You see anemia. Now, there could be other things driving it, but these are the 5 most common things that will drive the anemia, right? So if you have MCV, which is the size of the red blood cells, if it is over 92, and particularly if it gets all the way up to like 96, 98, 100, you want to start thinking about low functioning thyroid, that it fits that pattern. Depressed platelets are the same thing. In the liver, see, everything's kind of revolving around the liver. In the liver, you make something called thrombopoietin. And thrombopoietin goes to the bone marrow, and this is my bad picture of a pelvis, but goes to the bone marrow and activates it to make platelets. So thrombopoietin is in the liver. If you have a low metabolism, your liver is simply not going to function as well. It's not going to produce as it needs to, and you can have a low platelet count as a result. And any pattern of hypoglycemia, like a low LDH, LDH that's lower than 140, or any of the insulin resistance markers, any of these can do it. Okay, all right. So patterns associated with this. Okay, so let's talk about it. Primary hypothyroid is where you have something's going on with the thyroid. The most common one is Hashimoto's, but you could have low iodide, low selenium, and low zinc. If you don't know if somebody has Hashimoto's, or if they do have Hashimoto's, I don't use iodide, because there's a lot of research out there that shows that iodide can actually increase the problems with Hashimoto's. Now, some people will say as long as you give selenium with the iodide, it doesn't hurt anything. It can temporarily raise your TPOs, but then they go back down and that kind of thing. But I just generally don't use it. Okay, so patient comes in and they have a thyroid complaint of thyroid. And by the way, it's a good point here. So this patient comes in, they have low functioning thyroid. They don't know if they have Hashimoto's. They didn't know they had Hashimoto's because they went to a traditional doctor, and the traditional doctor saw a high TSH, gave them something, gave them synthroid, levothyroxine, gave them something, which she didn't take, but gave them something and called it a day. Why? Because in the traditional medical circles, it doesn't matter about any of these patterns because basically the treatment is just give them synthroid, levothyroxine, or leothyroxine or something like that, a nature thyroid armor or whatever the case may be, because they don't really investigate that. That's how we can be better, by doing this kind of thing where we will actually figure it out, and you can figure it out and develop natural strategies for it. But anyway, it's important to know whether it's Hashimoto's or not, because if you have Hashimoto's, you have an autoimmune disorder. And an autoimmune disorder is like a mouse in the house. If you have one, guess what? You probably have more. So unfortunately. So Hashimoto's, if you do have a Hashimoto's, then you have to go down a certain pathway as a care strategy, right? So it's important to know. So she did show that she had problems with fried and greasy foods. She does have some microbiome deficiencies. By the way, when somebody does this assessment, you see she has hardly any 2s out here. So she minimizes, so you just have to read into that. So she does have some blood sugar issues, insulin resistance, adrenal issues, and the thyroid. She had a few of those, not a lot. So she has a little bit of HCl problem. So when we start the care for this patient, we don't even know what kind of problem she has. We haven't done the test. But when we start care for this patient, we're going to have to keep in mind, as part of the strategy, we're going to have to work on improving the microbiome. We're going to have to get some HCl in that stomach. We're going to have to maybe do some liver function work. We're going to have to stabilize this blood sugar, and adrenals are just a downstream problem from this. So I want to say, there are foundational things that go on in our physiology. If somebody has a liver that's not functioning proper, they don't have good HCl in their stomach, their blood sugar's off, it does not matter what condition they have. If we don't address those, their ability to really get better is limited. It's just what it is. It's very foundational physiology we have to take care of on every patient. So in this case, there's hypothyroid going on. She came in with a diagnosis of it, so there probably is. We're going to do blood and look at it and analyze it, but we know no matter what, we're going to have to address these issues. Okay, so here's her blood. A really good indicator of insulin resistance is the triglyceride to HDL ratio. If it is over 3, then it's an indicator of insulin resistance, probably our strongest indicator, if you will. And if you look at this, I haven't measured this out, but it's somewhere around 9.0, which is 3 times what it should be. The other part is that we should have a cholesterol to triglyceride ratio should be 2 to 1. So in other words, if you have elevated, she does, if she has 227, I would expect triglycerides to be half that, 110, 120. She's not. So this is insulin resistance, but guess what? Her fasting sugar is okay. You cannot rely just on fasting sugar. You have to look for these patterns. That's what we're really explaining here. Look at this TSH. Should be 1.3 1.8 to 3.0. Now, here's the thing. If you see a TSH that's this high, I've never seen one this high that wasn't Hashimoto's. Now look, she has fatty liver going on here. Protein is elevated. It should be 7.1 to 7.5, a little elevated. This could be dehydration, but usually when it gets elevated, the most common cause is inflammation. And the most common cause of inflammation, we see this, is an infection. So we always have to keep that in mind. So her T4 should be, remember, 6.5 to 12.0. So what's coming out of the thyroid is low. And then we have the free T4. We said that should be 1.1 to 1.0, 1.0. So it's 1.0 to 1.1. So her T4 is actually 0.7. So she is making low T4. Okay. And of course the T3 is low as well. Everything's low. All right. And she has Hashimoto. She has the thyroid peroxidase antibodies. Keep in mind, this is not a thyroid. This is looking at the white blood cells. She has antibodies for this, okay? Eosinophils are elevated, so there could be a lot of reasons for that. Could be allergies, could be mold, could be Lyme, could be parasites. These are different things. We just have to investigate. And look at this. She has a bladder infection. So when I look at this, job number one is we've got to get bladder infection under control. Then we have to work, make sure digestion's going good. Remember, HCl, we've got to build that microbiome. We've got to support the liver. These are the major things that we need to do. I would also start with a glandular as well. So this is a post. Her triglycerides came back into the normal position where you should be, right? So cholesterol still elevated, not bad though. Her enzymes in the liver have straightened out, so that's good. White blood cells, okay, so we were at 700 on the TPOs, antibodies, now we're down to 100, which is a good change. And she doesn't have the bladder infection. So she's doing pretty good there. And she's feeling better. But this is over time. And I have to tell you, sweet Mennonite lady, but she's sensitive to gluten, and all people with Hashimoto should be off of gluten and dairy, all, whether you show sensitive to it or not, because gluten looks a lot like the thyroid, like the TPOs. And if you react at all to the gluten and build an antibody to it, that antibody will go straight to the thyroid and increase the problem. So you really want to avoid, and dairy as well, you want to avoid these foods. But she likes to eat a little bit of bread, as she says right there. And most of my patients comply. I've had this patient for 5 years, and we just try to play the game of minimizing. All right, so here's secondary. Let's talk about secondary. Now remember what secondary is. Let's talk about this. So here's the brain, mouth, nose. Here is the hypothalamus, and here is the pituitary. Okay. Now, the two most important elements for fuel for the brain are going to be glucose and oxygen. These are the two things that give fuel to the brain. If you have hypoglycemia and your sugar is crashing, then your hypothalamus pituitary will communicate with the adrenals, send alarm to the adrenal, if you will, to kick out cortisol, because cortisol very quickly gets sugar and oxygen to the brain. Well, here's the other thing that happens. Cortisol also feeds back the pituitary, and the hypothalamus. When it feeds back to the pituitary, over time, what can happen? Oh, by the way, let me back up. It feeds back to the pituitary, so the pituitary knows the alarm has been received, and then it quits sending out the ACTH, right? ACTH goes this way. Cortisol goes back to the pituitary, and the pituitary is rich with cortisol receptors. And over time, if you see too many cortisol surges, you're actually going to cause some pituitary fatigue. Now, if you get pituitary fatigue, it's going to affect your production of TSH. So here's the thyroid, whereas we should see 1.8 to 3.0. A very common place to find somebody when they have reactive hypoglycemia is somewhere on the TSH 1.2 to 1.8. It's a fatigued pituitary. It's just not putting out the TSH as well, and this is going to be a hypothyroid. These people can have normal T4. They can have normal T3, but yet they still have a secondary hypothyroid, okay? So here is actually a case of that. I'm not, from just time's sake, I'll let you guys read that later, but I want to get down to this. Here is the cholesterol. Now watch this. The cholesterol is at 288, right? But the HDL is high. So if you look at the cholesterol to HDL ratio, this is not cardiovascular. She does not have high cholesterol due to cardiovascular. I would argue against the use of statins anyway, but I can assure you, even if you're thinking medical and you love statins, this is not a case for statins because it's not coming from a cardiovascular disease. It's not that process. This is a low functioning thyroid. So therefore we have to address that problem. She might even have a little bit of genetics in there causing that to drive up, but I'll just say that's not the problem. So I'm not going to give them red rice yeast or natural things that bring them down. I'm not going to do that. I'm going to go after the things that are driving in this case it looks like, because we have this, the LDH is under 140, that is confirmation that she is crashing in her blood sugar, right? She's crashing every day, day in and day out. And here's the TSH right in that secondary, we said 1.2 to 1.8. If you're in that zone, you can think about hypothyroid. Now, let me go back. I've got a caveat here. If somebody's on a very, very low carb diet, not just somebody, I don't eat a lot of carbs, and then you start talking to them, they eat a sandwich every day and, a bowl of ice cream at night, they're saying they're on a low carb diet. If somebody's on a true ketogenic diet or a very low carb diet, then you may see that LDH lower than 140. But if they're kind of eating like most people eat, junky, trashy foods, whatever, and if it's lower than 140, that is reactive hypoglycemia. That fits that pattern. Of course, you would look if you have hypoglycemia. Do they have more energy when they eat? Does eating relieve fatigue? Do they get irritable if they don't eat? Do they get lightheaded if they don't eat? They get shaky, jittery. These are all kind of fit the pattern of the hypoglycemia. Okay, let's move on. Here's tertiary. This is a really important one. Excessive mucus in the lungs, fatigue, depression, and SIBO. That's what she came in complaining of. And if we look at this right here, not a lot to see there. That's okay. Her fasting glucose is 100. That's a little bit high. It's in the pre-diabetic stage. Look at this right here. Alkaline phosphatase is over 80. Now, it's not a slam dunk that you don't look at that analyte and say, oh, aha, I know what it is. It's sluggish bile. But guess what? It fits the pattern. Here is a low BUN. BUN should be 13 to 18. It goes low like that when you have a liver that's congested. So that fits the thyroid. That fits the thyroid pattern. Her TSH is 0.27. So anything under 0.1, you want the most common thing that'll do that. I'm talking about when somebody has hypothyroid. The most common thing that'll do that is an infection. And guess what? She has C-reactive protein that's at 15. Her neutrophils are at 70, should be at 60. And so this is an indicator of a bacterial infection. So a bacterial infection will cause that to happen. And I want to show you, I'm going to draw this out real quick. By the way, we lost 10 minutes on the first part right here. So I might go just a little bit longer on here to complete this. All right, so here's the thyroid. Here's the hypothalamus right here, and here is the pituitary. Well, as it happens, when you have an infection, what do you feel like doing? Going out and jumping on the trampoline, going out and running a mile? Or do you feel like just laying down and not doing anything? Yeah, you feel like laying down and not doing anything. Well, this is by design, because how do we get over an infection? Well, we rest our body so our immune system can be stronger and do that. When you're resting your body and you're sleeping, guess what else is happening? Your cortisol goes down. And when your cortisol goes down, guess what? Your immune system goes up. That's the reason why when you're sleeping in the middle of the night, your cortisol is low. That's the reason why your baby goes to sleep at night and then wakes up with a fever. And through the day, she or he's doing better, goes to sleep, takes a nap, fever goes back up. Why is that? Because the immune system's getting stronger, right? So that's one of the things we want to do is really knock that cortisol down. The body wants to do. Knock that cortisol down, knock that thyroid down, slow everything down so the immune system has the ability to fight whatever it needs to fight. And so viruses, bacteria, they can very easily influence the hypothalamus. When the hypothalamus gets influenced like that, it reduces and lowers that TRH to such a level that the TSH will actually go below 1. Now, if somebody's all hyper and they're up cleaning the house at 2 o'clock in the morning and they can't sit still, they can't stop talking, they can't, they're just moving right here, and their TSH is like 0.001, that's not hypothyroid, that's hyperthyroid. If somebody has a TSH of 2.7, that is not hyperthyroid. When you have true hyperthyroid, it's going to go below 0.1, right? It's going to go 0.01, 0.001. So you don't really have a hyperthyroid case at 0.27. I will put a caveat here, though. You always look at patterns. And if your cholesterol is way low, because hyperthyroid will do that, if they're all over the place bouncing, and then I saw a 0.27, then I would say that something else is affecting the TSH, but this is probably hyperthyroid. And by the way, it's a good time for me to say this, is that the TSH can bounce around when you have infections, daily life stresses, different things can bounce it around. So you never just look at the TSH and say, aha, that's what it is. That's why it's such a fallacy in the practice of medicine, or traditional medicine, where they just look at the TSH and sometimes told T4 and make an assumption what's going on with the thyroid. You cannot know by just looking at the TSH. You have to put the history, observations, physical exam, and look at things like the cholesterol, alkaline phosphatase, other things that are affected, the platelets, other things that can be affected in the MCV. The red blood cells and that kind of thing. So here's post-care. LDH is actually improved. No, that's not the LDH. It was not down before, but it was at 0.27, and now it's at 0.88. And the infection, she was at 15 on C-reactive protein. She's still fighting some infection there. It was a chronic bronchitis, but she's getting better. So, and you can see that she's getting better by that TSH coming up. All right. So I'm going to finish this with a case study right here. Actually, I don't have my tertiary. Okay, I have to go over one more thing. All right. So let's look at this. All right. So nose in the mouth. Here's my thyroid. So thyroid primarily kicks out T4, and remember, we go from T4 to T3 when that 5' deiodinase enzyme takes it off. Okay. So what happens is your T4 total should be 6.5 to 12.0. Your T3 total should be 115 to 180. And these two are relative to each other. And what does that mean? That means that if I see this come in at 6.5, then I expect my T3 to be about 115, right? If, and I'll give you an example here. If my T4 comes in at 9.0, and then it comes in at 86 over here, guess what? Relatively, that means there was a drop. T3 should have been about 140, 150 in that model, but it was 86. What does that mean? That means we have under conversion. All right, under conversion. Now, there is a list. And by the way, I have a PowerPoint slide in the beginning, the ones that you missed. I showed it to you briefly. But if you have an under conversion, there are a handful of things that'll do that. And this is what I love about identifying the patterns through the history, observation, and physical exam. I identify a pattern of hypothyroid. It's an invitation for me to run blood to understand why they have a low functioning thyroid, and there's actually a bigger prize here. Sometimes I'll have a patient and I don't know what's driving the problem, but I will do an extensive investigation running all the analytes for the thyroid for the specific purpose to figure out what pattern it is, because when I know what pattern that is causing a low functioning thyroid, then I can reverse engineer and start understanding what's causing the low functioning thyroid, which gives me an upper leg, or upper hand, I should say, on what's causing the whole problem. I hope that makes sense. All right, so for an underconverter, we want to think about stress. We want to think about high cortisol, okay? We want to think about liver congestion. You want to think about a poor microbiome diversity. Microbiome diversity is just to have a poor microbiome. We want to think about things like insomnia, not sleeping well. And also, you could be low in selenium deficiency. You could be low in zinc, and even low in vitamin D. These are all things. If you see an underconversion, and I have a better list at the beginning, but if you see somebody who's underconverted, you've done the blood test, and keep in mind, I don't just do it from people that I know have a thyroid problem, but if I see that pattern and I don't know what's going on anywhere else, I'll do a full thyroid workout because it gives me a great investigation tool to understand what's really driving the overall problem. Like I'll give you an example. I've had patients that come in with chronic fatigue and they just don't feel well, right? Just chronic fatigue. And the only thing that I saw was a TSH that was lower than 1. The CVC didn't show me anything. There were other indicators, but following that, I found more investigation, doing more extensive tests, I find a chronic infection. I didn't see it on any other indicator, and there was not a pattern for chronic infection. But because I analyzed the full thyroid, in this case it was TSH, I was able to see that they had a tertiary hypothyroid probably a major driver of the, the fatigue, but it showed me, look for infection. I distinctly remember that case. And I didn't know what else to do with them, so I just started them on a course of biocidin, and just see if I could flush it out. I did 1 month of biocidin, and after 1 month of biocidin, I took the CBC again, and it actually drew the infection out, and I was able to see what it was. And I believe it was a chronic virus. And I was like, oh, you've got a chronic virus. So why didn't CBC show it to start with? The reason why was because if you have a bacterial infection going on, you have a viral infection going on, everything's tugging everything everywhere, and you can see a case with a CBC that looks exactly perfect, but you've got more than one thing going on. That's exactly what was happening. After we flushed out some of the infection, we were able to see more specifically what it was. So look at this list. It's a very good list. Now, the next thing, I'm getting ready to wipe this off. The next thing is an overconverter, all right? So this is somebody whose thyroid, the T4 comes out, and it's at 6.5, and then the T3 is sitting over here, and it's 160. They're overconverting. What would be the problem with overconverting? You're making more thyroid. Well, the problem with it is here's the DNA right here, and there's a receptor. You can actually cause those thyroid receptors to become resistant because it doesn't like to see all that thyroid. In fact, that's why you make reverse T3. What is reverse T3? Well, here's my molecule here with my 4 iodines coming off just like this, right? Just like that. Now, the 5' deiodinase D1, D2 enzyme takes off this iodine. But guess what? Reverse T3 is when you take off the opposite iodide. It's actually iodide. When you take off the actual iodide, this reverse T3 will also land on that receptor, but guess what? It doesn't do anything. So why do we make something that doesn't do anything? Well, 20% of the time in normal function, that receptor wants to be left alone to cool off. And if you're over converting T3, what's happening is you are dinging that receptor too much, and then that receptor will begin to break down. When it breaks down, you're going to have thyroid resistance, and that's another problem. That's one of our patterns. But when you see thyroid resistance, there's nothing on the blood that will show it. And the things that cause thyroid resistance are going to be like BPA plastic, the persistent organic pollutants, benzene, industrial solvents, and those kind of things. They can actually land on the thyroid receptor and cause thyroid resistance. So that's something. Now, for the overconverter, the most common cause of that is going to be high testosterone in a lady. This is PCOS, but it's also going to be a lady taking birth control pills. That can also cause the overconversion as well. So those are the most common reasons for that. Okay, having said that, let's go through our case study. I'll be very quick. All right, here's a patient that comes in, kidney bladder infection, 6 months prior, took antibiotics. Well, 2 weeks prior to seeing us, she said, I'm not taking antibiotics. I got to figure out how to do this. So here is her, and she gave me permission to do this, by the way. She's diabetic and cholesterol's high. You can see by looking at this pattern, she needs a little HCl. She has had a history. No, she hasn't. She doesn't say that. She does have blood sugar issues. Obviously, she's diabetic. Okay, so she's eating a lot of bread, cheese, and pasta. Guess what? Stop eating cheese, bread, and pasta, right? That would be the first clue. We did food sensitivities. We did other testing on her. And, you know, what do you want to do? You want to palpate the thyroid. Is it enlarged, right? And by the way, you see that? That's kind of a male pattern baldness. That could be from low testosterone. It could be from thyroid. You know, it could be from those things as well. Lateral third of the eyebrow. Can you see that we're pretty much gone there? So this is low metabolism. It fits the pattern. She has a crease in the diagonal crease, which is more cardiovascular circulation. She has dry heels, dry skin, right there. You can really see the dry skin there. Now these little things right here, you see the pigmentation. That's really not hypothyroid, but it is cardiovascular disease. So we see that emerging. Fungal toes. if you have low circulation to the feet, and by the way, it could be from cardiovascular disease, but it could be low thyroid, you can grow fungal infections, right? Because if you have low circulation down there, you don't have enough white blood cell support to keep that at bay. And guess what? It's gravity. All the yucky, nasty stuff goes down to our feet. If we don't have good circulation down there, we can't clean that stuff up, and then we start fungal infections. Fungal infections never fly from the sky and attack you. Fungal infections are opportunistic. They're waiting for the right environment, and for us, the wrong environment, right? So anterior shoulder roll, okay, there's the thyroid. Listen to bowel sounds. You see that right there, skin tags, that's insulin resistance. You see that right there, this is acanthos nigricans. This is insulin resistance. So she has insulin resistance, low functioning thyroid, and she has cardiovascular. She's kind of a mess. I won't go through this. This is just that kidney punch sign. Okay, so here is the blood work. If you look at the cholesterol, it's 270, and her cholesterol to HDL ratio is 5.9. So it's probably a little cardiovascular, but guess what? It's probably also some low functioning thyroid. Her glucose is 104. Of course, she's diabetic. I think she's taking a little medication. Okay. Uric acid's high. Okay. We have a little bit of liver congestion, should be 13 to 18. And so I did a full workup on the thyroid because here again, I saw a pattern, so I wanted to see what was going on. So here's my T4 going to T3, okay? So my TSH is sitting at what is it, 4.17. So it's functionally, she has a functional hypothyroid primary, but I don't know about this. I think it's all the inflammation of the stuff going on, right? So our T4 is sitting at 9.8. If you remember from what we talked about, whoops, I got the wrong thing, 9.8, remember it should be 6.5 to 12, 6.5, 12. Her T3 total is at 106. So let me just reiterate these. Here's T3 total, T4 total. So now remember that this should be 115 to 180. And what does that mean? She has a big drop off. So what do we want to think? She's an underconverter. This is her thyroid problem. Now here's the issue. I was able to reverse engineer. I didn't put on there inflammation is something that causes poor conversion. Inflammation, high cortisol, stress, liver congestion, not sleeping well, GI problems, all this. So that's the list that we have to pick from. Now, doing further tests, look what I found. She also has a bladder infection. What's a bladder infection going to do? It's going to create a ton of inflammation throughout the body. So that could be causing some of the poor conversion, but also liver congestion in her case, insulin resistance, GI problems. These are all driving that. So I was able to find through doing that extensive thyroid workup, I was able to find that inflammation is going on, a liver congestion is probably going on, or GI microbiome, insulin resistance. These are things that I could see from that and gives us things to work on. All right, so the last thing, I'm going to go over this and then I'm going to go for questions. I have great news for you guys, everybody who's interested. We have a brand new DABCI program that's starting. It's going to be starting on November 19th and 20th. We're going to do it at Rolla, but it's going to be an online course. It's going to be Friday evening, I think 5 to 9, and then Saturday through the day. We're going to take off Sunday. So I think that's a good way to do it because you get at least part of the weekend, but we get to get a lot of great stuff done. If you are interested, and we teach all this stuff and a lot more, and we don't teach it hurriedly in an hour, but we help you really walk through this so you can learn it. But you can call 573-341-8292, or you can go to the website. The calling would probably be the best way. If you're interested in doing the DABCI program, you won't regret it. You're going to learn a ton of information, and it really will take you to the next level.